I'm Michelle McKinley. I'm a professor of nutrition based in the Centre for Public Health in the School of Medicine, Dentistry and Biomedical Sciences at Queen's. So for the next 35 minutes or so, I'm going to tell you about a study we've been working on for about 10 years now, and it focuses on finding acceptable, effective and scalable support for weight management after pregnancy. And this study is called the Supporting Mums Study. I'm going to share some of the things we've considered when we've been designing and developing this study and the lessons we've learned along the way in terms of shaping interventions and, importantly, evaluation design. So I'll start with a little bit of background and talk about the evolution of the Supporting Mums intervention and the pilot study we conducted. I'll then talk a little bit about the full trial, which we're conducting at the moment, and then just finish with some concluding remarks. So first of all, a little bit of background and context. So I think one area that we're probably don't do very well as researchers sometimes is bridging the gap between research and practice, and too much research ends and never goes any further than a journal article. And as noted by Milat et al. In this review, promising health interventions will only achieve population-wide impact if they are implemented at scale across communities and health systems. And there are many useful guides to scaling up population health interventions. This is one I particularly like from New South Wales Public Health System in Australia, and they make some very salient points about scaling up. So not all interventions that are shown to be effective in a research setting are suitable for scaling up, and that might be because scaling up and implementation hasn't been considered in the design. And the scalability of an intervention is not only determined by its effectiveness, but other issues such as the likely reach and adoption of the intervention. So what is the generalizability of the intervention? The costs of operating at scale. So cost effectiveness data is really important. And what is the likely acceptability and fit of the intervention within local contexts? And ultimately, and I think the key point here, and generally for this talk, is that scaling up is more likely to be successful if a systematic approach to scaling up is adopted from the outset. And by the outset, I mean from first designing the initial research. So really, as researchers, I think we should be considering factors relevant to scale up and implementation at the earliest stages of our research. And we should be thinking, have key design issues being considered in relation to the trial design as well as the intervention design, because sometimes we think about scale up of the in terms of the intervention, and we think of implementation in terms of the intervention, but sometimes we don't think about what we can incorporate into our trial design that will inform implementation and scale up. So the Supporting Mums intervention is focused on diet and activity, health behaviour change, and supporting weight management after pregnancy. So I just want to give you a little bit of background about this area and why it's important, and then talk you through the evolution of the Supporting Mums study. So in relation to maternal obesity in the UK, we know that about 50% of women will have overweight or obesity when they book in for their pregnancy in the health system. And this brings with it increased risks for the mum and the baby, both in the short and long term, which are shown on this slide. Some of those are shown on this slide. And an example of the long-term implications are, for example, the increased risk of gestational diabetes, which means for women then will have an increased risk of developing type 2 diabetes later in life. And this systematic review estimates that a third of women who have gestational diabetes will develop type 2 diabetes within 15 years. In terms of maternal weight trends, we know that women have an increased risk of weight gain during the childbearing years, and that pregnancy is often a time that women talk about as setting them on an upward weight trajectory for the decades ahead. Established predictors of long-term obesity for women are gaining too much weight during pregnancy, and that's called excessive gestational weight gain, and also not losing all the weight that they've gained during pregnancy, and that's called postpartum weight retention. And research shows that about 1 in 4 women will have substantial postpartum weight retention at 1 year, and that's around, by substantial, we mean around 4 to 5 kilograms. So being 4 to 5 kilograms heavier than they were at the start of their pregnancy. And postpartum weight trajectories in the late postpartum period are also important. This study looked at weight changes in the postpartum period up to 2 years postpartum. And specifically what they found between 1 and 2 years postpartum. So that's really the extended postpartum period. It's often the interpregnancy period for preparing for the next pregnancy. What they found was that about 1 in 4 women gained over 2.25 kilograms between 1 to 2 years postpartum. So you can see that there are a range of factors that can affect a woman's weight trajectories before, during, and after pregnancy. The importance of postpartum weight retention is shown in this study as one example, where they looked at perinatal data from which was registry data on births in Belgium. And what they could clearly see is for women going from their first to the second pregnancy, that there was an increase in the proportion of women with overweight and obesity in their second pregnancy compared to the first pregnancy. And this does have health implications, which they looked at in this study, both for women who started pregnancy underweight or at the recommended weight, and women who started pregnancy with overweight or obesity. So they found that gaining BMI units between pregnancies for women who were underweight or the recommended weight, gaining 2 or 3 units was associated with increased risk of gestational diabetes and pregnancy-induced hypertension. And for women with overweight or obesity, gaining 2 BMI units or more was associated with increased risk of cesarean delivery. So the postpartum period is an opportune time for interventions to improve health. As I've mentioned, it's often also known as the interpregnancy period or the preconception period for subsequent pregnancies. Women have new motivations around health, and there's the potential to influence the mother's health and also the wider family's health, given the central role of women within the family. But we shouldn't underestimate how challenging this time is also for women. And this slide just depicts what many women will talk about as the feeling of being overwhelmed at this life stage. And really, it's a culmination of physical, physiological, psychological, social factors that all combine at this stage of life and can make life feel very overwhelming for women. And this is really aptly captured in this quote from some qualitative research with postpartum women. This quote from a mum says, "It's hard to juggle everything you need to do. When you work, take care of the house, take care of everyone else's needs. As a mother, I think it is typical to say that a mother's needs always come last because you put everybody else before you." So that could be another factor in taking care of yourself physically, eating and exercising. It's hard to find the time to because everything else is so demanding. And this is a repeated theme in the literature. And when you talk to mums, they talk about competing demands, time and motivation issues. They talk about support, which can be positive and negative, and then add into that complicating factors like lack of sleep, postpartum depression. And women often talk about wanting to get back to feeling like themselves, but can really struggle to do that. And also because there are very few routine contacts that women have with health services in the postpartum period. Most contact that you do have is focused on the baby rather than the mum. So really, in terms of an evidence gap, we need acceptable and scalable weight management interventions that can fit into the busy lives of women at this stage in their life. We need to consider the specific difficulties in reaching this population. and the specific barriers to health behaviour change that come with having a new baby. And what we see in the literature is that what works at other life stages may not necessarily work at this time. So, for example, in terms of weight management, we know that there has been substantial success with group-based weight management sessions, but in the postpartum literature, this approach hasn't worked so well. And even with holding classes and group sessions on weekends at different times of the day, many women just haven't been able to attend those sessions. So the engagement has been really poor. So in terms of the evidence need and the gaps, the evidence supports the use of more flexible approaches at this stage of life. So more anytime, any place women or trials that suit women. But these need to be well-designed interventions and trials because, again, the literature is quite full of small studies that have had significant limitations in relation to mainly in relation to failure to recruit the population that they wanted to recruit, failure to retain enough participants in the study, and lack of engagement with the intervention. There's also a real lack of process evaluations and cost effectiveness evaluations. And in terms of duration, many of the studies in the literature in this area will be maybe 12 weeks duration. You might get some that are 6 months duration, but mostly these are very short-term studies focusing only on weight loss, very little focus on maintenance of weight loss, and also very little focus on scalability in general. So this call came out from NIHR 10 years ago, and it was asking what are the effective and cost-effective interventions for weight management after pregnancy. And so in considering the literature and some recent evidence at the time showing that interventions utilizing modern technologies were showing promise in relation to postpartum weight retention, we designed a study and submitted an application to NIHR. And we decided on the mode of delivery of the intervention as text message delivered, and there were a variety of reasons for this. Because it is an anytime, any place, anywhere mode of communication. We knew it had been used to change health behaviours before, and the text to stop intervention, which is a smoking cessation intervention, is a good example of this and had been shown to be effective and had been implemented and scaled up by the NHS. We also liked the fact that this was a relatively simple mode of communication. So even if you have the most basic of phones, everyone can send and receive a text message. And that allowed us to have consider reach across the socioeconomic spectrum. So we weren't concerned about exacerbating the digital divide. We also like the fact that in terms of functionality, it allows sustained contact over the longer term, which is important for behaviour change, and that it could be proactive as well as reactive and could allow individual tailoring if that was something that we wanted to include. And importantly, it's a really low cost intervention, so it does lend itself to scale up and being sustainable once it's in place. So we were successful in getting some funding for intervention development and a pilot study, and we developed the Supporting Mums intervention, which is a 12-month intervention, and it's delivered by text messages. So we spent a year working with PPI to develop our library of text messages, and full details of that are in our NIH report. The overall ethos of the intervention is to encourage a self-guided approach to diet and activity behaviour change and weight management, and that is supported in the literature. So really about providing women with a range of approaches and things they can do and let them determine what suits them best in their own lives. We incorporated specific behaviour change techniques based on existing evidence and things that were relevant to our theoretical basis for the intervention, which I'll mention in a moment. And we wanted to provide the information in layers to avoid overwhelming women. So, for example, the messages focus on dietary behaviour initially before then introducing a focus on activity behaviour. The messages provide advice, practical tips, they signpost to external resources like web links, YouTube videos, etc. That might be helpful. And they include many real-life relatable situations that are relevant to postpartum women, and a lot of those came from our PPI work. We, again, through review of the existing literature in our PPI work, we were careful to address many key barriers that exist for this population and incorporate those within the text message library. And really importantly is the tone of the text messages. And this is why we spent a year developing the library to make sure that we were getting the tone right at this really sensitive period of time. So the messages provide encouragement and motivation, they discourage guilt, they encourage self-reflection, but all with a friendly, accessible tone and including humour. To encourage engagement, which we knew from women was something that was welcomed in our PPI work. So I'm not going to labour the theoretical basis of supporting mums, but just to say that it supports both weight loss and weight loss maintenance. So in the first 6 months of the intervention, we focus on weight loss and the initiation of behaviour change for weight loss. And then in the last 6 months of the intervention, we move our focus to supporting sustaining change and maintenance of behaviour change. This is a summary of what our intervention content looks like. So it's a fully automated two-way text message delivered intervention. So you can see in the box at the top, all women receive a core set of messages that focuses on diet and physical activity, and weight management strategies. It addresses general barriers to weight management and health behaviour change, and those that are specific and most relevant to this group. And we embed behaviour change techniques within those messages. We also then included some interactive features to encourage engagement. And these include trigger words. So women could text trigger words at any time during the intervention. And the trigger words are tired, bad day, crave, slip up. And then they would receive a reply, an immediate reply in response to texting that trigger word. And we had a bank of replies that would be sent out from the system for each of those trigger words. Then the other interactive features we have are yes/no questions. So we've embedded a number of yes/no questions throughout the text message intervention. And these are questions that women can choose to reply. And if they reply yes or they reply no, that determines then an automated response that they get from our system. So these messages were, I suppose, designed to encourage self-reflection, to prompt goal setting, or just to check in with them and see how they were doing. There's 36 of these spread throughout the 12-month intervention. And then another feature we had is we also ask women to text us their weight weekly. And this is to encourage self-monitoring, because we know that weekly weighing is associated with better effectiveness in weight management interventions. So women could choose to engage with these interactive features, and this is something we'll be looking at as an indicator of engagement with the intervention in our analysis. We also incorporated social support, so women could opt in a friend or family member or partner to receive the same text messages that they were getting to help them on their journey if they wish to do so. And in terms of the frequency of the messages start out more frequent in the first 6 months and then gradually reduce. So by the end of the intervention, women are receiving 4 to 5 messages a week. So when we were considering our pilot study methodology, we did have some specific considerations in relation to gaps in the evidence, the population we were working with, and very much with an eye on implementation and scalability at the end of the day. So one of our first considerations was, what would the control group be? In weight management studies, it's quite common to see differential attrition between groups, and we have seen that in postpartum weight studies, and that then really affects your power and your sample size at the end of your study. So To avoid that in this study, we have implemented an active control group. So the active control received text messages about child health and development. And the active control group had, interestingly, the text to stop smoking cessation intervention had used an active control group successfully. So we have an active control group who also received text messages about child health and development. We carefully considered participant burden because, of course, as researchers, we were interested in loads of data that we wanted to collect, but we were very aware that every extra element you add to a study increases participant burden and increases your risk of losing participants to follow-up. So we very carefully considered exactly what we wanted to collect when and how we would collect it. For example, with questionnaire data, we considered using short form versions of questionnaires where possible. We included process evaluation and cost effectiveness evaluation because they have been notably absent from studies in the literature, and the process evaluation is really important for telling us if something works, why it works, and if something doesn't work, why it doesn't work. Importantly, we offered home visits for data collection because we thought there's no point in us having this accessible intervention and then having study methods that aren't accessible to women who have just recently had a baby. So we offered home visits for data collection. Now that really adds to the research costs because you are then taking more time to do the follow-up and paying travel expenses, but it's really proven to be really essential for this population and retaining this population in the trial. With regard to questionnaires, we considered how those would be completed and what would be easiest for this population. For example, completing via paper or online in one session or in small sections and with researcher assistance if required. And because of the time taken to complete the study measures at the home visit, including the questionnaire, we offered participants a £25 voucher for each data collection point. For the pilot study, then we conducted this in Northern Ireland with 100 women who were randomised to the intervention group or the active control group, and we collected data every 3 months for a 12-month period. And the women included in the trial were between 6 weeks and 2 years postpartum, over 18, and had a BMI over 25. So the report from the pilot study is published, and just in brief to say that we met our targets around recruitment and retention of the population, which had been a big issue in postpartum studies in the past. We had really good acceptability for the intervention and the trial approaches, and we did show evidence of positive indicative effects. So we wanted to take this to the next stage of conducting a full trial. And then when we were considering and preparing our application for a full trial, we did have an eye on scaling up and implementation if this was to prove successful. So we did want to consider this in our design approach for the full trial. Our first consideration was, did we need to adapt the intervention? And because we wanted to conduct a trial UK-wide involving all 4 countries in the UK and recruiting an ethnically and socio-economically diverse sample of women, we knew that it was going to be important that we conducted some intervention adaptation work before embarking on the full trial, and I'll mention that in a moment. So in terms of generalizability, when we came, at the other end of the trial, we wanted to make sure that we hadn't just conducted a trial with mostly white women who were well educated and well off, which is sometimes the case in our in trials research. So we really wanted to ensure we covered all of the UK in terms of the countries of the UK and recruited a diverse sample in terms of ethnicity and socio-demographic. And we did this by carefully selecting our recruitment sites and considering our recruitment approaches. We wanted to build in an inequality lens to make sure that we would identify and address any aspects of the intervention that may unintentionally increase inequity and digital exclusion. And we wanted to make sure that we used a broad range of recruitment approaches that would really allow us to test potential routes for real life implementation. So should this be successful, how would we tell women about it in the real world? How could women sign up for this? So it was important that our recruitment approaches mimic that. We also wanted to include some initial knowledge mobilization work, and that was really, I suppose, as a first stage towards informing implementation and scale-up plans. So we built in a stage of interviews with stakeholders who might be interested in taking such an intervention forward into the health setting, and as well as looking at effectiveness, cost effectiveness, and conducting a process evaluation, we wanted to build in some longer term follow-up to look at longer term behaviour change. So we built in a 24-month follow-up, so 12 months after the intervention has ceased. And this longer term behaviour change is really important for cost effectiveness models. So we applied and were successful in achieving funding to progress to a full trial. So just for the last part of the talk, I'm just keeping an eye on time here. For the last 10 or 15 minutes or so, I'm just going to tell you a little bit about the full trial, where we are with it, and some initial results we have on acceptability at the moment. So our design for the full trial is the same as our design for our pilot trial, except our data collection points are at 0, 6, 12, and 24 months. We do home visits, as we did for the pilot study, and we collect weight and waist circumference questionnaires. And then we also do interviews with some women at 6 and 12 months to assess acceptability and as part of our process evaluation. So as for the pilot study, women are randomized to the intervention group or the active control group. As I said earlier, before embarking on the full trial, we, bearing in mind that we wanted to recruit a diverse sample of women from across the UK for the full trial, we wanted to do some intervention adaptation in terms of the content of the text message library to ensure it's acceptable and culturally relevant for women across the UK. So we spent 6 months doing this before we launched into the full trial. And the focus really was on looking at the text message library in terms of language, humour, clarity, tone, and the cultural relevance. For this work, I'm not going to go into the detail of how we did it, but it was very much based on how we had conducted the PPI for our pilot study. We considered approaches that would fit in with women's lives. So we did online engagement. We also did telephone, email, whatever worked for women at this stage in their lives. And we started off with some group activity to discuss the messages, and then towards the end of our PPI, we did some more focused one-to-one activities where our PPI representatives reviewed the entire library of text messages. And we recruited women from London, Bradford, and Scotland for this PPI activity, using existing PPI networks, existing community networks, etc. So this work was really important for ensuring that the library did have broad acceptability before we embarked on the full trial. Mums commented positively on the friendly, supportive, and empathetic tone of the messages, and really, thankfully, the changes suggested were minor, but we did change, even though it was minor, we did change about 85% of the text messages in some way. And that might have been just small tweaks, a word here or there. Things specifically that women commented on were more culturally relevant foods, more emojis, avoiding some colloquialisms and idioms that were not going to be broadly understood by women across the UK, and reducing the length of the messages in places. So then in terms of considerations in our methods for the full trial, we, as I've said, we're very conscious that we wanted to try to ensure as far as possible that the results of the trial would be broadly generalizable across the UK. So we needed to consider this in our recruitment approaches for the trial. And we really decided to mimic routes that would be used for implementation if this was to be effective. So this involved NHS pathways as well as community pathways. And for example, with regard to the NHS and bearing in mind targeting underserved populations, we would focus on GP practices in areas of higher deprivation. We carefully selected the study sites, so they were across the 4 countries of the UK, but also so that we could achieve ethnic diversity, which we were never going to get from a Northern Ireland sample. So we worked, our sites in Bradford and London were very much chosen and focused specifically on bringing a lot of ethnic diversity to the sample. And in general, our recruitment approaches were varied and flexible across the sites as well. This slide just summarises where women heard about the study and all of the different routes that we use to recruitment. So you'll see about nearly half of women heard about the study from social media, about 20% from public health, local authority run community groups, 9% from other parenting groups, 9% from the Born and Bradford Better Start cohort, about 8% from friends and family, 5% from healthcare professionals or in healthcare settings, nearly 3% from a shopping centre in a shopping centre banner, and this was just in Belfast. So I feel I should give a shout out to the Abbey Centre in Belfast, who placed a pop-up banner in their shopping centre for the duration of the recruitment period when we were recruiting in Northern Ireland, and that really was very effective at just having a constant stream of women coming through via that route. And then we had about 3% from other pathways, and there was variation in what worked across sites. For example, social media didn't work in London at all, and their approach was much more around community groups and face-to-face recruitment in those community settings. So we will be preparing a paper on the recruitment approaches used in the trial, and Dr. Dunla Gallagher is working on that paper at the moment. In terms of our recruitment flowchart, we set out to recruit 888 women, and we recruited 892. So we achieved our target. We had about 2,500 expressions of interest in the year that we were open for recruitment, and about half of those expressions of interest were screened for eligibility. And then about 73% of those who we screened transferred to be randomized to the trial. So we had a very high translation rate from women who were eligible to be randomized and women who were actually randomized, because sometimes you can get a big dropout rate between screening for eligibility and someone being eligible and them actually signing up for the trial. Our sample characteristics then for the 892 women, so the map and the table just shows that they were recruited pretty evenly, slightly higher recruitment in Belfast and London and Bradford compared to Scotland and Wales. 39% of our sample are living with overweight and 61% with obesity. In terms of ethnicity, a third of our sample are non-white ethnicity, and over 50% are in the bottom 2 quintiles for the index of multiple deprivation. Stage postpartum is important as well, because this is another gap in the literature of what is the best time to engage women in interventions like this. So 38% of our sample were over a year postpartum when they signed up for the study. 30% were between 6 months and a year, and 32% were less than 6 months postpartum when they signed up for the study. So our retention rates, and which is really important and has been a challenging area in postpartum research, we were really pleased with our retention rates. So as you'll see in the box at the bottom of the slide, our primary analysis is conducted at 12 months, and our retention at 12 months is 75.6%. This trial is unusual, I suppose, in that it is a postpartum trial, and one of our exclusion criteria is if women become pregnant, they have to stop the study. So you will see along the side, we have noted the number of pregnancies. So in a trial, you would usually have, loss to follow up, and that includes withdrawals as well as those who were unable to contact. And then in this study, we have an additional category, if you like, which are the exclusions owing to pregnancy. So women who had to stop the study because of pregnancy. So our retention rate is 75, nearly 76%. But when you exclude pregnancies, actually our retention rate is about 84%. So we're really pleased with the retention rates in the trial. Excuse me. So I'll just finish off with a couple of slides about the acceptability of the intervention and what we have found so far. We are analysing the 12-month data at the moment, so I don't have a lot of data to share, but based on what we've been talking about and the design of the trial, the acceptability of the intervention and the acceptability of the trial methods is important, and I'll share those today. So at 12 months, we asked all our participants if they thought the Supporting Mums programme should be offered to other mums, and 96% overall said yes, it should be offered to all mums. The 95% of the intervention group said yes, and 98% of the control group. So I think that's really interesting for us and important, because the control group, you'll remember, receive text messages about child health and development, and we have collected qualitative data from the control group as well about receiving those messages, and the feedback we are receiving, though not formally analysed yet, is very much that women, particularly first-time mums, are finding that very supportive. So the control group in itself is potentially another thing for us to consider taking forward at the end of this study. We also asked women, how satisfied were you with your overall experience of the Supporting Mums study, so with the trial overall? And what you can see is that very, very few women were dissatisfied with the study. So a good indication that the approaches we had taken in the study and the methods we had used were acceptable to postpartum women. And then we asked women about perceived levels of difficulty with specific aspects of the study methods at the 12-month visits. We asked them about location of the visits, length of the visits, having their weight taken and their waist circumference and their height taken, and completing the questionnaires. So in terms of location of the visits, remembering that we did home visits, this was very positive, with only 2 people saying that this was very difficult or difficult. And I think, we can't underestimate how important this aspect of the trial was. And, this is one of the quotes we have from our qualitative work around the home visits. This lady says, wow, it's game-changing because it's just so much easier if the baby's having a nap or whatever. And at the beginning, I was just a bit overwhelmed with pregnancy, well, not the pregnancy, but the birth and stuff. So very, very good. So really highlighting how important trial methods are for the population you're working with. Length of the visits were also rated very highly, and we had carefully considered participant burden and how we would manage that at the outset of the study. Having weight taken and waist circumference and height measured was very acceptable, and completing the questionnaires, which was the element that would have taken women the longest amount of time to do, completing a questionnaire, this was only rated as very difficult or difficult by 2% or 13 women. So some conclusions then. For the Supporting Mums intervention, we've worked closely with and considered the needs of the target population at each stage of the intervention development, and also with regard to our research methods. We have considered factors relevant to scale up from the earliest design stages. We've recruited a really unique cohort of 892 postpartum women, and it's an ethnically and socioeconomically diverse cohort from across the UK. We have found that the intervention is, which is potentially scalable, is very acceptable to women, as are the trial methods we've used. And we've had really good retention, which will allow us now to go on to do that analysis to address effectiveness and cost effectiveness of the intervention. And alongside this, and I haven't had time to mention today, we do have a wealth of questionnaire data that we've collected on physical and mental health into the extended postpartum period, and that data in itself will address many gaps in the current evidence and will help to inform future studies. I'd just like to acknowledge the wider team who has worked on the Supporting Mums study, and many of whom have worked on it now with me for 10 years, and to acknowledge the excellent researchers at all of the trial sites who have recruited and been doing all those follow-up visits with the mums. And I'd like to thank the participants for signing up and taking part in the research, our PPI collaborators, and our trial steering committee.